presentation is going to focus on the nursing concept of healthcare law, which is concept number 53 in the Gittins book. Goals for this concept presentation will be: the student will be able to define and describe the concept of healthcare law. The student will be able to explore the theoretical perspectives of healthcare law. The student will examine nurse practice acts and legal principles important in leadership and management. And finally, the student will discuss the application of healthcare law within the context of nursing and healthcare. Healthcare law is defined as the collection of laws that have a direct impact on the delivery of healthcare, or on the relationships among those in the business of healthcare, or between providers and the recipients of healthcare. This slide provides us with a model of the definition of healthcare law. We see central in this model is healthcare law, which again, all these laws govern and impact healthcare. And surrounding healthcare law are the relationships that can exist within the definition of healthcare law. So we can see that healthcare law affects healthcare providers, healthcare workforce, healthcare organizations, the payers and payees, which can be the consumers of healthcare, as well as insurance companies, Medicare, Medicaid, and healthcare agencies. Looking at the scope of healthcare law, first of all, there's two types of law. We have federal law and we have state law. And federal law usurps state law. But when we're looking at healthcare and the U.S. Constitution does not clearly define or establish to the federal government the powers of making laws related to healthcare. So any powers not mentioned in the Constitution that are part of the federal government are kind of given to the states. So much of our healthcare law is provided through our state law. However, the federal government has found a way around this through the U.S. Constitution gives the federal government the power to regulate interstate commerce. So many of the healthcare laws that are provided by the federal government, for example, Medicare, they used their power to regulate interstate commerce to be able to enact that specific law. So laws are developed, once they're developed, which is through the legislation process, which is through Congress, and legislation is the process of introducing, adopting, changing, or repealing laws. Once the laws have been voted upon and signed off by the powers that be, it could either be the president, or if it is a healthcare law that the state wrote, it would be through the governor. Then these laws need to be regulated. They need to be put into action, and specific rules need to be established to ensure that the law is being followed. And within the federal government, laws are actually regulated through the executive branch, who actually then will pass along this regulation through different regulatory agencies. And the one that is specific for healthcare law is the Department of Health and Human Services. And within this department, there are different sub-cabinets, shall we say, that the Centers for Disease Control, the FDA, the National Institutes of Health, and so on and so forth, that they are delineated within the Gittins book. And finally, we have litigation, which is through the judicial branch of the government. And this is where courts address perceived wrongs that may have happened related to laws that have been put into place. Let's look at the theoretical basis for healthcare. Through this model, we can see that healthcare law is founded on many things. There's laws related to quality, laws related to cost control, laws related to equal access for all parties, protection of the patient, and even the structuring of professional businesses, and more so the buildings. And issues with healthcare law fall under 5 different types of law. There's tort law, which is actually the civil wrongdoing of someone, and that person suffered a loss that resulted in harm, making the person who committed the harm legally liable. Contract law deals with, obviously, contracts, and property law deals with property. Then there's constitutional law, and finally, criminal law. So malpractice really falls under tort law, because usually there is negligent. It is not a purposeful harm that was done to the patient. If there was a purposeful harm done to patients, as can be the case in some healthcare law, that would fall under criminal law. So in class, I'm going to put you into groups, and I'm just giving you this ahead of time so that you can start to reflect on this. I'm going to ask you to describe each law and then provide an example of the legal issue related to healthcare. And you can use some examples that have been provided in our Giddens book, or you can bring your electronic device to class and find some example through a web search. And then we're going to discuss the examples in class. As stated earlier in this presentation, there are both federal laws that govern healthcare and state laws that govern healthcare. And I did also state earlier that the federal government really doesn't have the jurisdiction to create laws related to healthcare based on the U.S. Constitution. However, the federal law has found a loophole around that with it, because the Constitution gives the federal government the power to for interstate commerce. So many of these federal laws are kind of related to that power and monies through Medicare and Medicaid reimbursement. So these are examples of federal laws. Social Security Act of 1965 is Medicare and Medicaid. The Consolidated Omnibus Budget Reconciliation Act has within it the emergency medical treatment of active labor, and you can read the model case study at the end of the chapter in Giddens. There's the Patient Self-Determination Act of 1991, which really allows patients, affords them the right to determine their own self-care, and that's why we have come about with advanced directives. We have HIPAA, which you're all aware of, and related to confidentiality, but the confidentiality part came about because the original, or the intent of the law, was to provide insurance to patients with pre-existing condition. And the confidentiality piece was because many employees were nervous that their condition would be reported back to their employer, and it would be known that it's a pre-existing condition. So HIPAA is also known as the confidentiality law. Then we have the Patient Protection and Affordable Care Act, which is pretty much the most recent law out there, and it affords health care to all citizens. And there is a video that I wanted you to watch related to Affordable Care Act for Dummies to become familiar with that law. Now we have state laws, and our professional licensing laws fall within the jurisdiction of states. We also have, the states are also responsible for licensing healthcare institutions, public health and disease prevention and control, patient consent, more about advanced directives, and then physician-assisted suicide. And you can read about those in the book. So we're going to move on to the State Board of Nursing, which is the governing body that oversees the licensing of registered nurses. And licensing laws have been put into place to protect the public from unqualified people providing health care to the public. So the State Board of Nursing is responsible for establishing the requirements for number one, for the person to obtain a license. They issue nursing licenses. They determine the scope of practice. They set the minimum education standards for nursing, and they manage any disciplinary procedures that are brought up against a licensed professional. Now I'm going to want you to visit the Nurse Practice Act. Here's the website. I will also have this website in healthcare law that you can just click on the link there. And I want you to, because you need to be familiar with your Nurse Practice Act. You need to, because you have to function within the scope of practice set. So I want you to look through specifically registered nurse, and are there any rules and regulations that surprised you or that you were unfamiliar with? And if so, which ones were they, and why did they surprise you? I also would like you to kind of breeze through the difference between an LPN and an RN, because you will need to be delegating, and you need to know what is inside the scope of practice for the LPN when you are designating care to them, so that you are not asking them to do something outside of their practice. And then I also want you to look at the scope of practice for the advanced practice nurse, and again, see what makes their practice unique and different above and beyond the registered nurse. Now that you're familiar with the scope of practice for nursing, RN, as well as LPN and APN, we're going to shift our focus so that you can protect your license and know what would constitute a malpractice suit. So first of all, 4 elements must be satisfied for there to be a malpractice suit. There has to be a duty, a breach of the duty, there has to be a harm to the patient, and that harm to the patient must be a direct cause of the breach of duty. So when does the duty form? The duty forms when the nurse initiates a nurse-patient relationship and takes over the health care needs of that patient. The duty that she performs to the patient must follow the standards of care set within the profession, and for us it would be nursing. And again, just for review, a standard of care is the degree to which an ordinary, reasonable, and prudent person would exercise in given circumstances, given the same background and experience. Now keep in mind, what makes this unique is because it can change from person to person because of the varying degrees of reasonableness expected between even geographical location and the healthcare setting that this happens in. So again, for review, the duty is once the nurse initiates the nurse-patient relationship and takes over the nursing care of that patient. That nurse has a duty to act within the standards of care set by nursing. If there's a harm to the patient, they're going to look to see, did that nurse fail to follow the standard of care, and was that failure a direct cause of the harm? And that's what would make a malpractice suit. We're now going to move on to the causes of malpractice for nurse managers. Yes, nurse managers can be held liable for failure to assign, delegate, and supervise within the acceptable standards of professional nursing practice. So what does the standard of professional nursing practice mean in relation to assignment, delegation, and supervision? It is that the person or the nurse manager needs to be aware of others' knowledge, skills, and competencies, and assign, delegate, or delegate appropriately. Just a quick review of the 5 rights to delegation. You have to be able to delegate the right task. So you have to first know, is this task even appropriate to delegate away, or is it the sole responsibility of the RN. For example, assessment. The nurse cannot delegate assessment. The RN cannot delegate assessment to an LPN. An LPN can be delegated the task of collecting data, but she cannot delegate away assessment. Is it the right circumstance? Is the patient stable enough and the outcome predictable? Are we delegating to the right person? So we have to ensure that the person delegated the task possesses and has demonstrated the appropriate knowledge base and skills competency. The right communication. We have to ensure that the person that's being delegated to has previously documented appropriate knowledge and skills base and competency and receives proper, clear instructions related to what needs to be done. And finally, the right supervision. So the person that the nurse that's delegating still needs to provide the appropriate supervision and follow up and ensure that the outcome has been met. So the nurse manager has a duty to orient, educate, and evaluate. That's another standard for a nurse manager. And inappropriate knowledge of a staff member's orientation, education level could actually make that nurse manager liable for malpractice. Now, some of this can fall under the doctrine of respondent, which means that nurse manager knew or should have known in the case of supervising or making assignments or delegations. So on one end of the spectrum, if the nurse has no reason to believe that that person accepting the assignment or delegation was unable to perform adequately and has proven that, then the liability is minimal or non-existent. However, the opposite can also be true. So if it is proven that the nurse manager in fact did know that the others were not prepared adequately or possessed the necessary knowledge base, that nurse manager can be held liable. So I think here we need to learn that we need to always be asking ourselves, is the staff person new? Has he or she completed orientation to the organization, to the unit, to the shift? Has this person participated in orientations to new equipment and procedures? Has this person been adequately supervised? And do I concur with the evaluation about the performance? Next, we're going to move on to failure to warn. The failure to warn concept is an avoidance of liability. Basically, nurse managers have the responsibility to warn about individuals suspected of addictions, violent behavior, and incompetency to appropriate professional colleagues. Nursing staff should be notified whenever there is cause to dismiss an employee for incompetency or impairment, unless the employee voluntarily enters a peer assistance program. Next, staff issues. Nurse managers can be held liable for staffing level issues, floating staff issues, or issues related to agency nurses. There's probably no other area so controversial as the area of staffing, and part of this is due to the fluctuation in patient census, and part is due to the shortage of qualified staff. So matching numbers and qualities of staff with the needs of the patients is always a challenge. 3 key issues have been identified. Staffing levels are mandated. Almost consistently, the wording is that adequate staffing levels must be maintained. So the question comes in just kind of like, what is a standard of care? What does it mean to be adequate? What is the right mix of licensure levels? Is education important? Most staffing levels are not specified in terms of numbers, so the challenge about staffing is that understaffing is always determined in court on an individual case basis, similar to the standard of care. The mandate from groups such as Joint Commission and others is that adequate staffing is maintained. And then there's lots of discussion around the term adequate. Adequacy is based on patient acuity, but considerable debate is also ongoing about the accuracy and flexibility of systems that exist to measure acuity. Actual number of people is one consideration. The next is the mix of staff. Are registered nurses sufficient to provide the required standard of care? Is the ratio of RNs to LPNs appropriate? What about nursing assistants? Most literature since 2001 has supported the idea that the number of registered nurses available to patients makes a difference, and few have indicated that additional educational levels for staff correlate with better patient outcomes. So if you are a nurse manager, you need to look to the evidence to see what correlates with better patient outcomes and staff appropriately. Being proactive as a patient side nurse or charge nurse or manager is important. If staffing is insufficient, you have the legal responsibility to report that staffing issues can affect or may impair patient outcomes. Again, you have the legal responsibility to report to the chief operating officer of your organization that the staffing issues are so poor that patient outcomes may be affected. So document your concerns, authorize overtime, reassign personnel, restrict admissions, and alert hospital administrators using the chain of command. Another issue surrounding staffing issues is floating, and that's refers to the moving of persons temporarily from an overstaffed unit to one that is understaffed. When you are floating someone, you need to consider the following: staff expertise, patient care delivery systems from where they currently are working to where they are going, and patient care requirements. You have to know the worker's skills, competencies, and knowledge. Finally, we're moving into the issue related to agency staff. And it used to be legal issues looked at agency staff as independent contractors. Now they're saying that they're calling it a parent agency, where if the patient sees an agency nurse and an hospital employee cannot see the difference between the two and assumes that both work for the hospital organization can be held liable. So when you have an agency nurse and you have to assign do patient assignments, you're going to err on the side of caution because there's no way you can really evaluate that agency nurse's competencies. So you would probably give the less acute, so more chronic, stable patients to that nurse. If for any reason the nurse manager suspects that an agency nurse is incompetent and is lacking of the knowledge and skills required to complete the job, she is responsible to convey that fact to the agency and send that temporary worker home. This falls under vicarious liability, where an employer is liable for acts of its employee if the employee was acting as an agent of an employer and the actions resulted in injury within that scope of practice. So healthcare institutions can also be held liable, and that's why they have mandated annual competency testing for its employees to ensure that their employees are possess the knowledge, skills, and competencies required to do their job safely. We're going to move on to laws related to protecting patients and reporting illicit behavior. First of all, most states have reporting laws for suspected child and older abuse and laws for reporting certain diseases and injuries. For example, gunshot wounds. That there's a mandatory reporting law for gunshot wounds, or sexually transmitted diseases. There's also, many states now have mandatory reporting of healthcare providers who are incompetent. It involves both legal and ethical concerns. Next, we're going to move on to informed consent. With informed consent, three things have to be present. First of all, the patient who is getting the informed consent has to have the legal capacity to sign the document. And one case is age. Anyone 18 years or older is legally has the legal capacity to sign informed consent. If they're under 18, they can be declared an emancipated minor, and those emancipated minors include anyone that is seeking treatment for substance abuse, communicable disease, or pregnancy. If any of those three criteria are met with the patient and they're under 18, they can sign their own informed consent. With legal capacity, they also have to have the ability to understand or the consequences of the actions related to what they're being asked to sign. The next requirement is that it is a voluntary action and that that patient was not coerced in any way by fraud, duress, or deceit. And finally, they have to be able to have the comprehension to make an informed choice based on what is presented in the informed consent. Nurses do not have the duty to provide the informed consent. They can serve as witnesses to the signing of the informed consent and the voluntary nature of the patient's signature. And if the patient questions anything following the signature of the informed consent, the nurse has an obligation to inform the primary health care provider so that they can come and clarify, amplify, and verify any concerns that the patient may have. Information that should be presented in informed consent is presented in the Yoder-Weiss textbook, box 5-1 on page 80. Moving on to privacy. Privacy is the patient's right to protection against unreasonable and unwarranted interference with his or her solitude. This extends to their reputation as well. So nurses can be found for if they defamate a patient's character, either verbally or in documentation. And finally, confidentiality is the right to privacy of the medical record, which we are all well aware of in the HIPAA law. There are many employment labor laws that you can become acquainted with in the Yoder-Weiss book. I'm not going to go through these individually because you can read them. There's the Equal Employment Law, Age Discrimination, Americans with Disability, Affirmative Action, Equal Pay, Occupational Safety and Health, Family Medical Leave, Employment at Will, and National Labor Relations. Here are some interrelated concepts with healthcare law. There's healthcare economics, healthcare policy, and ethics. And it can be quite confusing sometimes which is healthcare law, which is healthcare policy. And I think the best way to describe healthcare policy is analogous to the nursing process related to outcomes. So the policy statement is what the outcome we want. For example, Affordable Care Act. It's a health policy that all Americans have access to health insurance. And healthcare law are the nursing interventions or the regulations that are put into place to get to that health outcome. Healthcare economics and healthcare ethics can help define both. I don't know if you can think of an example of an ethical situation that eventually brought about a health policy with its implementation or interventions regarding the law. And healthcare economics can also drive healthcare law and healthcare policy. I look forward to some good discussions in class following this PowerPoint presentation. Thank you.